Hi, everybody. Welcome to another public health forum session hosted by Nivarana. To those of you who are tuning in for the first time, Nivarana is a public health platform which is exactly meant for these kind of discussions. And today we'll be discussing the Right to Health Act, which has been being implemented by the Rajasthan government. And we have a lot of people here to discuss the same act, which has gained a lot of buzz on Twitter recently. I'll be hosting this session with Pranav. Pranav, if you can just go ahead and introduce yourself.
Hi, I'm Pranav Chatterjee. I'm a public health professional interested in particularly infectious diseases, antimicrobial resistance. Thank you, Parth, for hosting this. And just before we start, I would like to invoke the Chatham House rule to ensure that we have a trusted environment to talk about this complex and somewhat polarizing issue. So the Chatham House rule reads as follows. When a meeting or part thereof is held under the Chatham House rule, participants are free to use the information received, but neither the identity nor the affiliation of the speakers nor that of any other participant may be revealed. So we are free to use the information being discussed at today's forum, but it would be best to leave out the individual affiliations and designations from that so that there is freedom of expression without fear of retribution. With that, I hand it over to you, Parth.
Thank you for that, Pranav. The whole agenda for this talk today is to discuss the pros and cons related to the Act. There's a lot of confusion on social media in the general public, and there are multiple versions of this Act which are circulating online. So firstly, I hope that we all are reading the same Act, which is on the page, I think 28, it starts when it gets translated in English. Initially, it's in Hindi. So I hope that all of us have read the same document. So just to start off, I'll introduce myself as well. My name is Parth. I am a first-year postgraduate resident from Nivarana Medical College, and I've done my undergrad from CMC Vellore. I'm interested in public health, public policy. Happy to be here and learn today from all of you. I would first request Bruno sir to start off this discussion. And if you could please introduce yourself first and then go ahead with your points.
Thank you, sir. I am Dr. Bruno. I'm a neurosurgeon, and I have been associated with the planning of various schemes with Government of Tamil Nadu, including the Transplant Authority of Tamil Nadu. And then I was the nodal officer for Tamil Nadu Accident and Emergency Care Initiative, as well as the first nodal officer for hospital management system. So I have a bit of idea in how government schemes are planned and implemented. So I will share what I know in this session. Just yeah, is the PPT visible?
Yes, it's visible.
Yeah, okay. So we'll go directly to the point of discussion. So essentially, before starting about this, I'll tell you that I am a full supporter of right to health. I have been demanding it on various forums for nearly past 2 decades. So I am not against the concept of right to health. And I want this act to be implemented in Rajasthan, not only in Rajasthan, I want it to be implemented in all the states. But in this particular act, I find few problems and I want to highlight the problem. I am highlighting these problems not to protest against the act per se. I am highlighting the problems so that they be corrected and the act be implemented at the earliest. So we say it is a right to act, right to health act. Basically, we need to understand the concept of rights and duties. And rights and duties are usually two sides of the same coin, and they go together. Your rights don't come from thin air, and your duties are not poured into a black hole. And a right always comes from another duty, and a duty always serves another right. This is the key concept which every one of us must remember. And if you take Constitution of India gives us fundamental rights. that is each and every one of us as a citizen has a fundamental right. And it is the duty of the government, whatever be the arm of the government, be it a legislative, executive, judiciary, to provide that right to us. So our right as a citizen is the duties of the government. And Constitution does not only talk about fundamental rights, there's also something called as fundamental duties. And our duties as a citizen is the right of the government to demand us do that duty. So whenever you talk about a right, there is a corresponding duty, and whenever you talk about a duty, there should be a corresponding right. And when it comes to healthcare, actually, we have got three main stakeholders here. One is the government, second is patient, and maybe you add relatives also to the same bunch together. Next will be doctors, hospitals, and hospitals. If you just analyze this, you can see that patient has the right. That is, the patient has a right, and that right can be either a duty of the doctor or a duty of the government. And the doctor also has a right, and this doctor's right can be duty of the patient or duty of government. And government has a right, and this government's right can be the duty of the patient or duty of the doctor. And you just put it the other way around and look at the duties. The duties of the patients or the rights of the doctor or the right of the government. Duties of the doctor is the right of the patient or right of government. Duties of government is right of doctor or right of patient. So if you see, you will see 12 points being listed, but essentially they are only 6 because one duty and another right go together. So you see here, the duty of the doctor to a patient is the right of the patient from doctor. Government to patient is patient from government. It is essentially same. So I don't want to bore you up. So essentially what we need to understand is one duty should be matched with another right. Now, what is this flag? Can anyone tell me? Or this logo? Which country does it represent? No answers?
I think chat box there is one answer, the Democratic People's Republic of Korea.
So this represents Democratic People's Republic of Korea. So Korea, that is especially North Korea, it is called as Democratic People's Republic. So don't go by the title of the country and think that there is democracy in the country. Okay, so titles can be misleading. I have the same problem with this act. This act, though it is called right to act, the right is only in the name, because the bill actually, this has a fancy list of rights and there's a fancy list of obligations. The duties of the government have been written as obligations, but the point of concern which I am raising repeatedly is that the both are fancy list and they don't match with each other. And since they are not matching with each other, they cannot be implemented. And if you force implement it, the doctors will end up paying for it, both in terms of money as well as in other problems. And the second problem I see from this is the word emergency is not defined. Okay. So for example, if it is a headache, how can you say it's not an emergency? A headache can be due to a rupture of subarachnoid berry aneurysm, then it becomes an emergency. A stomach pain can be due to an acute abdomen, a ruptured ectopic or a perforation, then it becomes emergency. Any limb pain can be due to ischemia, it becomes an emergency. Now, a person is coming to as a headache, should the hospital do a MRI or CT? A person is coming with stomach pain, should you do an ultrasound? Or a person is coming with limb pain, should you do a Doppler? And if you are doing a headache and finding that it's a normal scan, and then you give a paracetamol or at the maximum you treat a migraine, will this qualify under emergency? Will it be reimbursed? If it is not reimbursed, who is going to foot the bill? This is the very key point which is missing. As long as we can say it is right to act, it is fine. But if when you are saying right to act, you please define it. Because anything, any emergencies, any stomach pain, any headache, any limb pain is an emergency. Of course, I did not add chest pain here because we already, that everyone knows. But from a layperson should also understand that there's a big problem in this when you are not defining it. And you do a patient comes with acute abdomen, not acute abdomen, with severe pain, you do a scan, the scan is normal, you give a ranitidine, the patient will goes well. Now, does this cost of scan come under emergency or not? As is it defined in the Act? Can any person who supports the present version of Act answer this question? And who will reimburse? If you see, the Act specifies the duties of the doctors, but it has a very long list of regulators. It says who all can come and inspect the hospitals, but it doesn't specify to whom the bill has to be sent. Should you send the bill to the district deputy director, to the DHO, to the collector, to the director of medical services, to the state health authority, to the finance secretary? To whom should you send the bill? Now, don't please say that this will be given in the regulations. Come on, everything else you have defined very clearly. You have defined the state health authority. You are allotted 14 crores for state health authority. You have everything else. That is all the duties of the doctors and right of the patient has been defined. But reimbursement is conspicuously absent, and I don't think that it is an accidental absence, and that gives the doctors or anyone criticizing the Act a valid ground. And will you pay the full bill or will you pay only the part bill? Suppose what happens if the hospital spends 30,000 for a patient, but they are going to pay only 15,000? Who is going to pay the remaining 15,000? And there is another point which is raised, is that why can't doctors work for free? Come on, if there is no obligation to work for free, and even if it is asked for free, you can ask the doctor's service for free. But what about the consumables? What about the Foley? What about the ICD? What about the tracheostomy tube? What about the sheets? Who is going to pay for that? It is not that one thing what we all need to understand is emergency management 40 years ago and emergency management today is different. 40 years ago, emergency management was injection TT half cc, injection AMP is gentamicin, that's all. Today, if you are doing a proper ER work, the consumable, any person who is coming under a red category, if he is resuscitated, the fluids being used, blood being used, everything, the minimum bill is 40 to 50,000. Now, who is going to pay for that? And when will it be paid? 1 day, 7 days, 30 days, 1 year, 3 years. Suppose a hospital is going to treat one patient a day and they are not going to pay it. Well, at the end of 1 month, it is 12 lakhs. So how long should they wait? So my opinion here is this may look strong, but I have gone through all the clauses and I find that this bill, though noble in aim, in the current version is flawed, incomplete, and it's just a mirage. And if you are forcing this, it will do more harm than good. And okay, I have given the criticism. Let me also give the way forward. First, you match the duties and responsibilities. Otherwise, there is nothing called right to health. If you don't bring a right act for right to health or right to education, whatever be the right, if you are not matching the duties and responsibilities, it is just a mirage, it is just a gimmick, it is not a real intention. Second is, government has to pay. Let us be clear about it. All the taxes you pay, be it a professional tax, be it GST, be it income tax, everything you are paying only to the government. You are not paying any tax to the doctors. So who has to give back? Only the government has to sponsor the bill. You cannot ask the doctors to pay back. And you have to pay the full amount and you have to pay immediately. And money must be allotted to the scheme before starting it. If you are not even allotted the money, if you are not even telling who is the reimbursement authority, then everyone will be forced to conclude that you have no intention of paying. And another suggestion, which is, this is such a big scheme, and why they didn't think of going in phases. Okay, you start this act in one taluk, you empanel 10 to 15 hospitals, you start in one taluk, allot the money, frame the guidelines, disperse it, find out what are the pain points, learn the lessons, modify the guidelines. Then from one taluk, you go to one district, then you go to 4 or 5 districts, and then you upscale to the state. And when you are doing it, every hospital will know what is happening in that taluk. Today is an era of WhatsApp, everyone is connected to everyone, whether it is UG mates or PG mates. So they will see that, that hospital treated, they got the payment. Now we need not oppose. Instead of doing a pilot, instead of doing any phase 1, if you are merely pushing such a crucial act all over the state, I don't think it will be workable. And the next important way forward I am suggesting is don't shoot the messenger. Okay, when doctors ask a doubt, clarify. When doctors question, answer. When doctors criticize, change. Don't immediately label every doubters, questioners, criticus as money-minded, business, against right to right. What is happening in social media for the past 3 days is not only the media, I understand, okay, they may not know the intricacies of the field. When they have a wrong opinion, I don't have a problem. But many doctors also are using very venomous words against others, as if the other person who is talking doesn't know, and saying that blah blah blah, money minded, blah blah blah. Such things won't really lead to a proper outcome. And another way forward is there is one scheme in Tamil Nadu which is called Nammai Kaakum 48. It's a Tamil name, okay. Innuyir Kaapom is Innuyir is life, okay. Kaapom is save. Nammai Kaakum 48 is, by the scheme, government is sponsoring the first 48 hours of the treatment in select private hospitals. Government will pay. Okay, so essentially, I'll tell you what they have done is there is an absolute budgetary certainty. This is what is missing in Rajasthan. Okay, and we have prepared district-wise trauma plan as well as service mapping of ambulances. So whenever a person is picked up in the ambulance pilot or the EMT will call the call center, and they will decide which hospital to go based on whether facilities are available in that hospital and the distance. And then up to 1 lakh per individual has been given assured here. And this includes all road traffic accidents who belong to Tamil Nadu, and even other state persons, migrants and foreigners. If the accident is within Tamil Nadu, they are covered. Okay. So the initially they sanctioned a corpus fund, and in the current financial year, this is actually last year's, they have 100 crore has been allotted initially. So here what we do is, the accident victim can take the first 48 hours treatment in cashless basis in the empanel hospitals in approved procedures. So this is one point which is missing in Rajasthan. Rajasthan gives a blanket point. Here we have approved the procedures. And if the victim comes to be unstable after 48 hours, the clear guidelines is given. Now, if the victim, that is the accident patient, has CMCH, the treatment will be continued under government insurance. If he is not a CM insurance beneficiary, the patient will be stabilized and shifted to a government hospital. The patient is not willing to go to a government hospital, they will be treated in the same hospital, and they have to pay the fees from the resources. So here, if you compare the Rajasthan Right to Act bill, okay, that is with the guidelines of the scheme, and I am willing to share the guidelines to you. You will clearly say that that is a very lofty scheme, which is not where the duties and rights are not matched and no responsibility is fixed. No, that is no stepwise responsibility, no job chart, nothing has been fixed in Rajasthan Act. Whereas this Act, everything has been written in black and white. And if you may, those from other states, you may be surprised to know that we have treated 1.5 lakh patients in the scheme from December 2021 to last few days ago. Okay, so 1.5 patient, 1.5 lakh is not a small number, and no doctor protested in Tamil Nadu, no hospital protested in Tamil Nadu, because the scheme was proposed in 2017. IMA and doctors, hospitals are called for meeting. Multiple rounds of meeting were conducted, and the GO was issued only in 2021. We did a groundwork for 4 years, and once we rolled it out, and we rolled it out in stages, there was no opposition. Rajasthan can also very well do the same. And instead of merely branding the questionnaires as antisocial and all, they need to sit up and address the pain points. So I think since every one of you have to contribute, I have rushed through it. If in case of any doubt, you just WhatsApp me. You can WhatsApp me in this number. This is the most frequently I use this, and I'll be willing to share my points or any doubts. So thank you, Parth, and thank you others for the patient listening. And if anyone has any questions, I'll be more than eager to answer briefly.
Thanks, Dr. Bruno, for this very considerably well thought out discussion and starting us off. So I would like to invite Siddhesh to take on the mantle of the pro stance for the Rajasthan RHA bill. Over to you, Siddhesh. We will follow the format of a short debating or quick debating style, where we will invite substantial comments for about 4 to 7 minutes, followed by 2-minute rebuttals or inquiries. So over to you for your main substantial comments, Siddhesh.
Yeah, thank you so much, Pranab. And thanks, Parth, for organizing this. Thank you, Dr. Bruno, for your presentation. I think it puts together the anti-position to the bill pretty well, and filtering out like the noise that we have been experiencing on social media. My kind of a couple of concerns that I have with regards to the anti-position. So I think pro-position, if we are just talking about like right to healthcare as a concept, my guess is that everyone in this call right now should be pretty okay and open to that. So I don't think that's what we are debating. What we are debating is this particular piece of legislation and how far it goes or where it falls short with regards to keeping its promises. I do want to clarify that it is a piece of legislation, meaning that it's not a policy framework, it's not operational guidelines, it's not a strategy document. So kind of like my first concern is that expecting that all the details that Dr. Bruno was asking for from this document doesn't seem fair. This is not just a claim or a personal opinion, but I invite all of you to go through all major important bills and acts that have been passed by national or state governments in the last 10 years. And you can pick a piece of legislation which goes into details about operational guidelines, because that's not what a bill or act is supposed to do. A bill or act is supposed to put together the major normative goals and ideas that are under purview here. From my perspective, that's what the bill is trying to do, and it's trying to do that pretty well. Dr. Bruno gave an incredible description of what is Tamil Nadu doing, but again, I have to mention that all of those details were taken from operational guidelines. I'm not sure if Tamil Nadu has a right to health bill, and if there is one, I would like to see if the bill has so many details, including the operational guidelines with regards to definition of emergency and with regards to how the triaging or referral system should be. I'll just give one more example, the Mental Health Care Act, which was passed in 2017. Again, it has a lot of lofty goals. A lot of those have not been achieved, and we still don't have clear implementation plan for achieving some of those. But that doesn't take away from the validity of the bill itself. So that's, I think, the first thing that I want to clarify. I understand the concerns about missing details. I also appreciate the critiques about beyond missing details, about lack of clarity with regards to things like reimbursement, which is important. But from a pro position towards the bill, I think it's putting together a list of goals. It's putting together a list of obligations, responsibilities, duties, whichever way we want to put it. And then it's saying as to who is responsible for which part. And more importantly, and I feel like this has kind of, I mean, the main discussion has been very, very largely away from the main point, which is the rights of the patients, something that India still massively struggles with, that our medical community doesn't seem to focus on as much as it should, although there are people who focus on that. But we definitely need more focus on rights of patients and how do we increase awareness about those rights. So from a pro position, I think the bill is doing a decent job of putting all of that together in a brief document. I'm hoping that there are a whole bunch of SOPs and implementation guidelines and strategies and plans coming up following this, that will include like some of the details that Dr. Bruno mentioned, which are very critical. Another thing to maybe slightly debunk is also that the money allocation has not been specified yet, so we don't yet know how the 14.5 crore rupees, which is like the extra burden on the state, how it will be spent, when it will be spent. Although one thing that we do know is that only 5 lakh rupees out of 14.5 crore will go towards SHA and deployment of DHA. So it's not as if that money is going more into bureaucracy. That said, I'm hoping that it goes towards reimbursement of OOP, and maybe some of it goes towards making the public health system better. Even as a proposition, I do have one quick critique for the bill. I feel like it's still weak with regards to what we should do about our public health system. It should have focused more on what the government plans to do and what government's responsibilities are with regards to strengthening the public health system. Since we know from the NSS data that at least in Rajasthan, about 48% people still visit public places and 52% visit private places. So it's not one of the states like my state, which is Maharashtra, where the major chunk of healthcare is kind of taken care by private sector. So Rajasthan is still a state which relies heavily on its public health sector. I was hoping that the bill would go more strongly on that instead of focusing on, how to basically give an avenue for private healthcare and manage it through reimbursements. So yeah, I think that's mostly like the reason why I am pro for this.
Thanks, Siddesh. Your comments are well taken. And yeah, I don't think anybody here who's even on the critical side for the act is debating the need to have right to health or access to health for everybody. And I think we're all focused on trying to improve the way in which the act gets implemented. So the next speaker that we are going to invite is Dr. Raghuraj Hegde. Dr. Hegde, over to you, sir.
Hello. Yeah, I think a lot of the points that I wanted to say, Dr. Bruno has already spoken. The few things that I want to say is basically, again, like Dr. Bruno mentioned, that I'm not actually against the law in total, or I mean, the bill in totality and everything that it's promised to make. But I would like to say that these are just words. What we need is, there are a lot of, all our laws, if you see, whatever laws that we make or whatever bills that are presented, all have lofty goals, or everything is so nicely worded and as if it's, everything's happening on ground. But on ground, a lot of things are missing. The cursory reading of the bill, I feel that there are a lot of opportunities for rent seeking. So there are ways that a lot of power is vested on the state officials to inspect, to fine, and to decide on what constitutes an emergency, what needs to be reimbursed. All those things. I mean, it's not explicitly mentioned that they can do all this, but I foresee that from the way it's worded, it's going to be like that. Of course, you can say it's all assumption and all those things, but it is like that. There are a lot of opportunities for corruption as well as rent seeking from those intermediaries. And I have one big problem with this thing is that they make it a punishable offense to treat clinically. So if you're like basically having this guidelines oriented thing. So if you're going to have like, oh, this is defined as an emergency, but on ground, if the doctor doesn't see that as an emergency, and if he treats it like that, and the patient then gets to sue, gets to tell the government that no, it was an emergency and he treated it as per his whims. So then the doctor is in trouble, the hospital is in trouble. But in fact, what the patient had doesn't become, because how we treat is basically clinical acumen, and then we take calls based on, and there are a lot of 50-50 calls. We may be right, we may be wrong, but there are a lot of 50-50 calls which the state should not have the power to dictate. So I am really against this guidelines where the state defines what an emergency is, what needs to be investigated, how much investigation. And then at the end of it, we don't know whether whatever is spent on the investigations or interventions is going to be reimbursed in full by the government. So, and another problem I have is that it's not defined that where the patients can approach. So if a patient approaches a very small, very ill-equipped nursing home, in case of an emergency, and they don't have the capacity to manage such an emergency. The moment they tell you need to go to a higher center, the patient is obligated, because the messaging is such that you can just enter any hospital and get the get whatever treatment that any big hospital can offer. So then there is a problem that there is a violence against the personnel, not necessarily doctors themselves, but there can be anybody, right from the watchman to the nurses. There is a big chance that there is you're inviting these kind of issues, because there's a lot of things that are not clarified. So even before you invite, like in such a large scale, if you're getting a bill of this large scale, there has to be a phased manner. There has to be people taken into confidence, not just the doctors, hospitals, but even the public also. So they need to be taken into confidence that these are the places that you need to go, and these are the ways you can access it. And if you're having trouble, what are the helplines that you? So these needs to be discussed in detail at the community level rather than from a top-down approach from the parliament. So and another problem is that so they have right to health for the patient, yes, but once the grievance redressal, having a single window, all that I have no problems with, but there is no right for the aggrieved doctor or the hospital to approach the court. There is and then they say the state officials will take a call on good faith, and they cannot be prosecuted for taking a call on good faith. And there is no definition of what is this good faith implies. And so that is another point. And one more point is that this messaging from the thing, and the problem, I don't like protests. So because the moment there is a protest on the streets, the nuance of what you want to ask is lost. So now from where it could have been that you could have taken the right to health bill and included the private hospitals and private doctors in the bill to actually help with the implementation of the whatever right to health bill that you had proposed. Now it's on the streets, and they are demanding that en masse withdrawal of the bill because they are worried. So because they feel that if you start talking in like nuanced terms and not in binary terms, all of that is just going to be swept under the carpet and it's not going to be taken in. So the maximalist position now is not because the doctors who are protesting don't think that patients should have the right to health, or patients should die in an emergency on the street without any care given. It's just that so much fear has been created. So what happens is over the next few months, at least, there is going to be a lot of paucity of the hospitals that are available in the near term, and people may refuse to take in, saying that we don't have staff, we don't have they may shut down until they are clarified as to what actually the right to health, whatever the bill implementation is. If it becomes a harassment tool, then these things are not going to open up again. So this in the end, the patients are going to be they're going to suffer because of less. Earlier they would at least, even if for a payment, they would at least have somewhere to go in a case of emergency. But now, since it's deemed as like you can walk into any thing, they would assume that the hospitals would not take the responsibility to take on the financial loan. And also because if this reaches because a lot of the hospitals are not like big corporations and which can afford to take in a lot of losses in the emergency room. A lot of small nursing homes will stop their emergency services because that fear is created now, because that is the issue. And I think more or less everything else Dr. Bruno said was also, I think I agree with most of what he said. I don't think I have any disagreements over what he said regarding the other issues.
Thanks,
Yeah,
Dr. Hick.
that's about it.
That is a very interesting take, and I really appreciate your bringing out the concerns regarding how the implementation is going to happen. One thing that Dr. Bruno also talked about, and I'm opening this up for comments from everyone here, is that distinction between legislation and implementation, because it seems like at this point there is going to be an implementation framework that will be put in place subsequently. So I would like to invite thoughts on how that is different from the legislation, and whether the legislation should make it clear that there has to be a pilot implementation as such, as Dr. Bruno proposed in his discussions. Or, like Utkarsh points out in the discussion, the day this bill gets signed, the right to ask for services is enshrined for all the residents of Rajasthan, and you cannot really do a phased implementation per se. So inviting comments on that or any other aspects of how the policies are being framed around this legislation. Utkarsh, you can make that point you were discussing on the chat box if you want to come online.
Yes, sure. So the point I was trying to make is one that it is a right-based legislation that one needs to understand. That I can, as a citizen of the state, I have Dr. Siddesh has compared it to the Mental Health Care Act, which is an unfair comparison because it is not a right-based act where the constitutional rights and the legal rights. Even I can move to high courts if my legal rights are not respected. So the day governor signs this bill, I have the authority even to move to high court if according as the and there are such wide rights, wide provisions that it has been given. So it will affect and people will be using it for rent seeking. We need to understand the background we are coming from. We have been before 1991, this everything that we are seeing right now used to apply to industries where everything looked very good in paper. Everything was asked where bureaucrats were given in charge to legislate or basically give judgments on if something has happened rightly or wrongly. But when it went so it turned into Inspector Raj. So what we are fearing is this turning into Inspector Raj and not really helping patients. It will helping bureaucrats more. This SHA and DHA also seems very heavy on bureaucracy, which any person would not understand. Why would you give a health authority which will deal with questions like was this an emergency, how was doctor supposed to go, how did the doctor do the right thing? So out of all those things, why are the DHAs and SHAs primarily dominated by the bureaucrats? So that that clearly seems to me like a like a for sure conclusion that it will become an instrument of Inspector Raj and rent seeking. That was the point I was trying to make.
Thanks, Utkarsh. The current legislation as it is framed, as far as the state health authorities of legislation, of logistics and treatment guidelines are concerned, they have memberships from, I do agree that the leadership is based out of administrators. For the State Health Authority for Logistical Grievances, the membership are an IS officer as the chairperson, Vice Chancellor of RUHS as ex officio member secretary, Joint Secretary Medical and Health as member secretary, Director Medical Health as ex officio member, Commissioner Medical Education as ex officio member, Principal of SMS Medical College Jaipur as ex officio member, nominee of the Ayush Department by rotation as another ex officio member, and 2 members nominated from the Indian Medical Association Rajasthan state as members. So that is the State Health Authority for Logistical Grievances. And for the treatment protocol, the ex officio chairperson is Vice Chancellor of Rajasthan University. Joint Secretary Medical Health is the member secretary, principal SMS ex officio member. State government nominees from any other principals of medical colleges is ex officio member. A nominee of Ayush department by rotation is ex officio member. And again, 2 members from the IMA Rajasthan state as members. This is in the 53-pager document. And it is, you're not just hearing a whole lot of medical people, you're hearing all medical people, Siddesh. This is all medically qualified people. And although the act does state that they want to do social audits, none of these authorities actually have community memberships. Over to the group about thoughts about any of these constitutions of these authorities. I think the treatment authority is led, or treatment protocol authority being primarily medically oriented makes sense. What about the logistical grievances authority or the district health authority, which is also primarily medically oriented, with the exception that they have the Pramukh Zilla Parishad and 3 Pradhans of Panchayat by rotation. Over to the group on your inputs on this constitution of these groups. Siddesh, do you want to take it up? You were putting a comment on the group.
Yeah, no. I think I was just asking for the composition of the SHA and DHA, and whether that involves representation from different groups. To be honest, my another concern is that the whole representation and conversation right now seems to be largely geared up towards private practitioners, more specifically private practicing doctors who may be leaders of their individual institutions or their small clinics, dispensaries, or other places. I also think that that's an important part of the overall stakeholdership with regards to the bill. Maybe some of this composition would have been more diverse if we would have included other healthcare workers, if we would have included patients,
And I think
public health people.
the previous version of this act actually had a more diverse, it was more inclusive. It had patient, it had NGO leaders. So I'm not really sure what happened and why they edited that bit out. But like you were mentioning.
Yeah, so I mean, I ideally that would be my concern with the current representation right now, that it seems not bureaucratic, but actually largely people practicing clinical medicine in a very specific setup.
And I personally like, just to, we've been talking about a lot of cons all this while, and I totally agree with what Dr. Hegde and Dr. Bruno have mentioned. But we are missing out on something very important, which even Siddesh mentioned, that is, rights of patients, which till now has not been a very major conversation in India. And this piece of document actually lists down the rights of the patient quite well when you talk about getting the documents from the health system, which might sound like it should happen everywhere in the country, but I don't think it's happening. Based on my personal experience, a lot of the patients who actually don't come with any medical records because the doctor denied them investigations or whatever. So that this clearly lays down. Another thing is that because I am from a public health background, community medicine background, this is actually seeing health from a more social and a more preventive aspect rather than just curative, where it talks about sanitation, it talks about clean water supply. So those things are also included in this act, which once it's down in this act, you hope and expect that legislation guidelines will come after this, sort of incorporating those things when it comes to health in general. And another thing is the obligation of the government part. Dr. Bruno mentioned the duties and the obligations are not matching, but at least we have something down on paper now, where the government is saying that it is obligated to make sure there is accessible, affordable healthcare, and even mentions quality of healthcare now. So those are some terms which I feel are very welcome in a piece of document which is legal now. And that was some of my thoughts on this. We also have Patralika with us. If there's anything you would like to share, Patralika. regarding this whole discussion and right to health?
I haven't actually read the act, so I wouldn't like to comment at this stage. I'm happy to listen. But of course, I think the right to health, like everybody agrees over here, that's a very major. And from the point of view of patients, I think public is listening and would be watching all these arguments, from the medical side as well as thing, because the public definitely wants now. And I'd really like to know how in other countries also this is done, because if you have an emergency, you should not die. You should not think simply because you don't have money. So in principle, I agree with the legislation, but I also see that I think the clarification, there needs to be definitely a more detailed conversation on some of these fears. And there seems to be, to me, what comes across also as a certain trust deficit between the government and the private doctors, that you're believing the worst of each other. Now, something also needs to be done, I think, to deal with that, because you can't really have proper implementation of any act if key stakeholders completely do not trust each other. So that's just very briefly, but I haven't read the act, so I plan to do that tonight. So I wouldn't, I don't think I have anything more to say. Thanks.
Varun has put the link to the 53-pager, which is how the bill stands as it has been presented in the chat box. Parth, you can also drop the PDF there if that helps.
Yeah. Any other comments from anybody else who has joined us here?
Yes, thank you. I was hoping to call you to air your views that you've provided several comments in the chat box. If you could speak up, thank you. You're muted, Karuna. Your hand is up, so you're welcome to speak up. Seems like there's some problems. We can't hear you, Karuna. Okay.
Even with Dr. Varun, if you would like to share any thoughts from your side.
Oh, you're unable to unmute. Let me see if we can unmute from here. Parth, can we unmute?
Yeah, they should be able to, yeah.
Hello.
Hi, yes, sir.
Yeah, so I just want to add a few things. One is I appreciate the comments by Dr. Bruno that there are rights that come with duties and rights should be matched with duties. That is all very good, but we must also consider the power equations when you talk about the different stakeholders. And when it comes to power equations in a particular emergency setting, it's my experience, and it seems to me that the ones who are actually the ones with the least power are the patients, actually, patients and relatives. The private hospital, they have to, in an emergency setting, listen to whatever the doctor is saying and whatever the hospital decides. They don't have that much say in such situations. So I feel this act is a very good step in the sense that it gives patients more rights, and it gives patients a little more power in that situation. And I think some of our fears are unfounded. We take small incidents and then we tend to blow them up and make mountains out of molehills. But in most situations, this is what I see, that actually patients are the ones who are actually deprived of power in such situations, and they are the ones who have to run around in an emergency, either when they are referred from the private center to find the next center, they have to hunt by themselves, they have to arrange transportation by themselves. So I find that the way the act has proposed giving more rights to patients is a very positive thing, and we shouldn't just throw the baby out with the bathwater by focusing on small aspects of implementation that can always be dealt with later. And the fact is, the reality in India is that many patients end up dying in such situations, like for a snake bite. Even in Kerala, there was a death. There were many deaths actually. but I remember very clearly 2 years ago, there was a death of a 10-year-old girl who was bitten by a snake in her school. And she was taken first to a private center. They didn't have ASV. She was referred to a taluk center where the ASV was available. But there was a delay there for treatment. Meanwhile, the duty doctor decided that she should be referred to the medical college. And on the way to medical college, during the transportation phase, she became serious and she couldn't reach the medical college. So, I mean, there are so many circumstances like this where either the private hospitals are scared to treat because of medical legal issues, or because of lack of availability of things that should be widely available, or because of issues regarding payment. So I think the fact that the government is willing to step in is also a positive thing. And I've also seen many instances like this. And in fact, I think in some aspects, the bill doesn't go far enough. For example, the Kerala state has a scheme that to treat even migrant workers. And just like Dr. Bruno said, migrant people who are involved in accidents actually get free treatment for the first 48 hours. And that is something very good. And it's disappointing that in Rajasthan state, they've restricted this act to only residents. And the migrant population is not covered actually. So, I mean, these are my 2 cents about this bill.
Thank you, sir, for sharing your thoughts on this act. Siddesh, why don't you just unmute yourself and you've added a few comments. If you can just share, then unmute yourself and share them.
Yeah. No, I think my main comment is still that this is a piece of legislation which is not supposed to have details about clinical management and specific cases or specific instances where things might go wrong. It would have been great if it would have had that, but that's not a necessity here. I hope there are going to be documents which do that, and that has been the pathway historically, where we have acts and then we have implementation strategy documents or larger planning and larger like planning documents. So my guess is that there are going to be a series of documents following this. But yeah, I kind of invite everyone here to maybe dive a little bit into India's or even other countries' health legislative literature and point and kind of like see for yourself that how health legislative documents are framed. And my guess is that you'll probably see that they are not supposed to be they are supposed to have lofty goals, but they are not supposed to be comprehensive with regards to the peculiarities of day-to-day situations. So I think that's the only point that I wanted to make. Also, if I may put like a quick question to this pretty somewhat divided panel, I am curious to know. I'm not a private practitioner in India, but I'm curious to know as to what ignited the passions of private practitioners. Because at least on social media, the major conversation, especially the anti-conversation, seems to be coming from a very particular group. So I'm just curious to know as to what created that.
Can I answer?
Yeah, go ahead, Dr. Bruno. I was just going to say that you might be the best person
I
to
am
answer.
not a doctor in Rajasthan. Okay, I am from Tamil Nadu. I am pointing out the deficiency of the act. So this, I am not sure that my answer may be politically correct or so. It may be even a blunt answer, but let me say it. There are 2 sets of doctors who I can see. Okay, or maybe I will not just doctors, individuals. First group is the one group who have been already seeing such acts. They have been going through various legislations, and they are more, maybe intelligent is not the word, but they are more experienced in knowing what this act will do. Those peoples who are more experienced, who are more awareness about what legislation in paper will become in reality, are questioning this. The second group who does not have the experience or exposure to understand how legislation in paper will pan out, or just getting excited about the word right to act and supporting it. I'm not sure whether this is a very politically correct answer. If it hurts anyone, my apologies, but this is the answer for your question.
I kind of have a quick follow-up on that. Do we have examples as to where this has happened before, where people with more experience have been cautioning about an act and it like everything kind of went wrong?
Yes, lots of experiences. That's what everything else in the past 20 years, if you see what is happening, the answer is there. We cautioned about inclusion of healthcare under consumer courts. Okay. Well, from that, I can give you, I don't think it's a forum to do that, but the very reason why you are asking the very reason why you asked this question proves my point.
No, I kind of missed that. Proves what point?
That those who are not aware of the what is happening in the Indian healthcare scenario are blindly supporting this act.
Okay.
We are supporting right to health. You have to understand this point very, very clearly. We are not against right to health. We are only pointing out the deficiency in this act. Now, the counter argument you are getting is, oh, right to health is good, right to health is good, patient right is good, patient right is good. Okay, when we are pointing out the specific problems, we are not getting any answer for this. Everyone supporting this says, oh, right to health is good, patient right is good, blah, 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 blah. The discussion here doesn't happen because those who are criticizing this act are criticizing the real actual problem clauses in the act, and those who are supporting this act doesn't even want to understand what is the reality, and they are just glorifying right to health, right to patient rights, all those things. That is why there is what we say, both sides don't see eye to eye.
Yeah, Dr. Bruno, thanks for that. But since like we are okay with conversation being blunt, can I put forward a point? I think one of the reasons, this is my hypothesis, but I think one of the reasons private players have been very aggressive on social media with regards to challenging this act is because the private practices in India is largely governed by how money is made. And I think they are scared that if I can complete, I think they are scared that this puts an impediment to their money making abilities. And that's why there is a lot of fear which is coming out in terms of trying to say that we are trying to point out deficiencies. Maybe another rhetoric to explain this is that I have never seen this passion in last 5 years about any other healthcare policy or about any other healthcare discussion. I have never heard a statement from IMA about national health policy. I have never heard a statement about IMA for National Mental Health Care Act. But suddenly IMA and even a lot of, again, I'm saying there is a very specific group of people, which is a large group, that seems to care about this even when they are not living in Rajasthan.
Can I answer?
Yeah.
You have not heard about IMA does not mean that IMA has not made statements. Okay. If you have gone to the IMA website.
Can you show me a statement from IMA about NHP for National Health Policy? Because I have seen the IMA website and I didn't find a single statement about any major healthcare policy.
No, now I'll tell you, this is a very dangerous domain. Did you mail IMA and ask them whether they have given the comments or not?
But shouldn't it be in public domain? They're all statements about this particular act are in public domain, right?
Let us not assume. You can only say that IMA has not commented on national health policy after you go to mail them and check them. Okay. Now websites sometimes are maintained by amateurs. Some areas the things may be broken. You just cannot conclude based on this. Okay. No, what I'm saying is lot of conclusions, lot of assumptions are based on only assumptions and conjectures. It doesn't work that way. Of course, private doctors are aggressive because they are going to be affected.
And when we say affected, can we be specific about how they will be affected? It's about the reduction in incomes or profits, right?
No, it is about not only reductions in income. They may not even have any income. They may be forced to spend from their pocket. They may be harassed by the non-medicos. They may be physically attacked by the patients. All these are already happening in India. Okay, doctors getting attacked are already happening in India. Doctors getting harassed is already happening in India.
Dr. Bruno,
when you don't have a reimbursement mechanism, how long should a doctor pay from his pocket?
Dr. Bruno and Siddesh, just to step in for a
Okay.
second, IMA does have comments on national health policy, on the National Digital Health Mission ecosystems. And if you put IMA comments on National Health Policy India, literally the first Google search output is IMA's presentation. I have not gone through the slides. I just Google it right now. There is something. It may not be substantive, but there is something. And the absence of prior critiques does not invalidate current concerns. That's the other thing that I would like to say. Priyanka, I think you're on the panel. Can I invite you to speak up and raise your points?
Yeah, hi. I've not read the act, so excuse me for that, but I'm here just to learn. I was following some of the counters, the arguments made in the counters, and the fact that not everything is spelled out in the act and is expected to be spelled out in the rules and regulations, that makes sense to me. But there's a very specific point with Dr. Raghuraj Hegde raised, which is that there is a penalty for clinical management of the patient, which obviously seems to be within the act itself. And I was curious if, I think Dr. Siddhant, I just wanted to know what his thoughts on that were. Like, that does sound tricky, Siddesh Zadevar, because that does sound kind of tricky. I mean, if you impose a penalty for clinical management, which I'm guessing should be left to the judgment of the doctor. So I'm curious to listen to his response on that.
Oh, I guess my response on the penalties part of the bill.
Yeah, Siddesh, I think she's talking about you.
Yeah. No, I don't agree with that. I think that's definitely, I agree with Dr. Hegde there, that's definitely a tool for maybe more systematic, and which can go towards like bureaucratic harassment of like individual doctors. I definitely don't support that part.
There are legislative provisions within the former MCI's acts, currently in the NMC Acts, which lays down what a doctor is supposed to do and when a doctor is culpable for negligence. Interestingly, this piece of legislation says it's in addition to everything else that exists and not in abrogation of anything else. It does not make it clear whether these punishments are in line with the current examples or current situation legally with respect to culpability of a physician. It's not clear, and I think that's a bit of a red flag. And I agree with Siddesh, Dr. Hegde, and Dr. Bruno that this is a tricky part of the legislation, particularly because particularly at primary and secondary levels of treatment, a lot of treatment happens clinically without confirmatory testing because the time or infrastructure may not be available for that. And so retroactively, will the physician be held responsible for how they treated a patient or not becomes a very difficult question to answer. And I think I agree with Siddesh's point that that is a bit of a concern for a lot of the physicians, not because of the money or other issues, just because it may create other follow-up problems. Utkarsh, you've had your hand raised for a while. Please come online. Utkarsh, you can unmute and speak up. Also, I think there was another person's hand raised. Sorry if I've missed it. You're welcome to speak up.
I think he has left the chat. I have a question to ask, which is like open for comments. So this right to health, I am like, one thing I've gained out of this conversation is that I'm sure that all of us are for right to health. But for a state like Rajasthan, considering that we are aiming for universal health coverage in the next 7 years, if a state like Rajasthan was to proceed to UHC, how long should it actually wait? Like there's another argument coming up that the state is in a lot of debt, finances are not that great. Now, like who will reimburse, things like that. But how long should one state wait to actually make health a priority? And if this Right to Health Act is actually a good step towards that, it might not be the best written act, might have a lot of flaws, a lot of loopholes, but still is it the need of the hour? If anybody can just comment on that.
Can I comment? Yes, sorry, I actually missed my mic and I was not able to unmute myself at that time. Before I come on to what we were discussing, before I wanted to unmute because there were some points being mentioned where it was being said that private players are working based on profit, and private players, I really want to see that, or maybe I want to express this, that we have been through this. I feel that we are forgetting where we are coming from. The last 70 years, the first 40 years, we did this whole debate that are private players supposed to be working for profit, or are they supposed to be working for their the larger interest of the society? And 1991 settled the debate that practitioners, private players in the whole society should always be working for profit, and that is the best contribution of theirs to the whole society. So no, I don't realize that they should not. It is the job of the government to ensure that there's universal healthcare. It is the government's job to incentivize them to come into their schemes. You cannot mandate, you cannot put a bureaucratic framework over them, so that you can uh, push everyone into your framework. The basic constitutional rights, Article 19, right to do business. I have never practiced and I'm not supposed to practice. I have aspired to be a community medicine person all my life, but I don't understand this discomfort of people with profit. Profit has always benefited the first 40 years of our country. We did not develop as we should have because we did never incentivized profit for private players. Post 1991, we have in every industry, IT has grown because healthcare will also grow, and that does not mean that people who don't have money should die. No one is saying that. Everyone wants right to health, but that should be the government's responsibility and not my someone else's responsibility. You are not supposed to be the government is supposed to do that. So that is my, and in the way forward also, I would I was about to say this, that it the government should incentivize the private players and help it, or maybe it could have been some specific things that you could have mentioned. This is a very overarching or very vague and wide powered legislation, which I don't feel that will lead to real empowerment of patients, and much more to the rent seeking mindset of the bureaucracy. And just last one thing, I'll conclude in 30 seconds. One question was there, where is this anger coming from? So I really what my feeling is that there has been a growing mistrust among the administration and the doctors from a very long time. There has been constant no action on the violence against doctors, always the support of the patients, which has become a lobby in some districts of Rajasthan. I am from Rajasthan. So there has been become a lobby of people who just have the job that every 15 days they will do a dharna outside the emergency, and they will say that they were not treated, and the doctor will to save his reputation pay him some 5 lakh 10 lakh rupees. So this mistrust was constantly growing, and when they saw that bureaucracy could come in with such wide ranging powers, they saw what is coming for them, and then they played. Every private player is also losing a lot of money in strike every day. We need to understand that. So it is not that they are angry for no reason. Everyone, big hospitals are losing lakhs of rupees. Private players are losing significant amount of money also. So they are feeling that they are coming for them. So it is a very growing mistrust which has brought to this. Thank you. Thank you.
Thanks, Utkarsh. Your point about profit not being a dirty word, for at least for the corporate players, is well taken. And it Siddhesh's point about the difference being between profit and profiteering is also a valid justification. Just for a clarification, on page 35 in the amended version of the Act, it says, provided that after proper emergency care, stabilization, and transfer of patient, if patient does not pay requisite charges, healthcare provider shall be entitled to receive requisite fee and charges or proper reimbursement from state government in prescribed manner, as the case may be. While it's still not very clear to me what the mechanism of asking for reimbursement is going to be, there is at least some guidance on the fact that it's not expected to be free treatment. Once the patient is stabilized, once the life-threatening event is over, perhaps there are some mechanisms to seek reimbursement. On that note, Abhishek, you've had your hand raised for a while. Apologies for the wait. You're welcome to.
Yeah, on the same point which you raised. But the problem is very practical problem. What I'm not from Rajasthan, I'm from Karnataka, and I'm not a private practitioner. I work in a medical college. But even with private medical college, the problem is most reimbursement from the state or the central government comes after 2 years, 3 years, 3.5 years, even after the Ayushman Bharat, because I know, because my department is in handling the Ayushman. So it comes after 2 years, 2.5 years. So till that time, the main issue, I think, what public players or private players or private hospitals against it is that, see, already we have taken your Ayushman scheme, we have taken various schemes in which the reimbursement is coming after 1 year, 2 years. Now adding to that, you're adding again one more, this one where they don't know where the reimbursement comes. Because see, everybody is supporting right to health, but we also need to see hospitals also is a place where thousands of other livelihoods are made. So hospital also has to pay those people. So you need money to run anything. It is not that only doctors need money. Hospital needs money to pay their group D workers, sanitation workers also. So at the end of the day, hospital also need money to run. Probably, I think one main point why the distrust is that, like you pointed out, the reimbursement mechanism is not very clear. Probably instead of, and like the person, I forgot his name, person said everything need not be in the legislature. That point is correct. But what stopped the government from coming out and saying that, okay, these are the things we are going to do, and then put forth the bill, instead of putting first the bill and then causing these agitations and this one. So that is, I think, one point which I wanted to make. Yeah, thank you.
Abhishek, I think it's a very interesting point you've raised. So basically what you're saying is that have the implementation framework in place before you actually go ahead with putting the legislation.
Yes, you could have waited for, say, 1 2 months, had a discussion, and then implement it. Because I don't think anybody in this country or any private, let it be student, PG, let it be intern, let it be top practitioners, is against right to health. Nobody would want our patient to die. So I think that was one point which I wanted to do. Thank you.
Thank you. That's a very interesting point, and it invokes the chicken and the egg problem a little bit, because the very governance frameworks that are entrusted with developing the implementation guidelines or implementation documents are being established by the provisions of the legislation. So that is also a bit of a challenge, figuring out who establishes the implementation guidelines and why does the newly constituted SHA, DHA, why are they going to be held accountable for a piece of implementation plan established by somebody else who has no stake in how it gets implemented? Over to you, Parth. I think we've had
we've had a pretty long discussion. Unless and until there are no further comments from anybody, I think this is a very healthy discussion. Finally, this was something which was actually needed rather than the whole noise that was going on Twitter. And I don't feel my question has been answered yet. How long should a state wait to finally have a Right to Health Act is something I'm still trying to answer. That Bruno, sir, if you could, yes, sir.
Sir, as I told you, when Right to Health Act means that, for example, in Tamil Nadu, we have all the government hospitals already free. Okay, treatment for in all government hospitals, all PHCs, all GH is free. Every day, around 6.7 to 7 lakh patients comes to various outpatients. Okay, around 10,000 surgeries happen every day. Okay, we conduct 7 lakh deliveries in the government hospitals. Now, what do you think that the Right to Health Act will add to a state like Tamil Nadu? What essentially are you demanding by this act? Can you specify?
No, I don't think we can compare Tamil Nadu to any other state in the country. Tamil Nadu has worked over the years.
Okay, now if you are saying that right to health means that you need to have free treatment, then there are government hospitals for you.
No, what I'm trying to say is Tamil Nadu over the years has invested in health. It has been a political priority in Tamil Nadu. And if you look at states like UP, Bihar, Jharkhand, there specifically, the health has never been a voting issue, unlike in Tamil Nadu or in Kerala, where people demand good health. So if somebody is not demanding good health, it ultimately comes to the government to provide good health. Because, if nobody is demanding, at least the government should provide it. And that's when a legislation like this, steps in, where the government has actually written that it's the government's obligation to provide accessible care based on population density, geographical area, things like that. So unless and until something like that is on paper, you ultimately can't demand any investment in health.
No, I still have one basic question. Why does government need an act for it to do something?
That is more for moral.
The government does not need an act for the government to do something.
It doesn't. But that is, I think that is from a very, very Tamil Nadu perspective, is what I'm saying. I have worked in Tamil Nadu. Like, I was there for 8 years. And I have seen that the ministers there, the government there is motivated to, to make a difference in health.
Yeah.
And, that is more of I don't know if you can call it a cultural, related to cultural thing or something, but rest of the country, until and unless I personally feel if there is no legislation in place, nobody can hold the government accountable for providing good health.
No, my point is, I agree with this Right to Health Act, but my point is any such act will only force everyone other than government in reality. Government doesn't need an act to act by itself.
No, I agree. Again, I agree with your point. But
no, there's okay. I'll tell you to digress. Tamil Nadu, for example, we have 30 government medical colleges. We have around 300 plus district hospitals. We have around 1,800 primary health centers. We have nearly 400 school health teams. Okay, all of this have been done without any Right to Health Act.
But I can't take the Tamil Nadu government to Rajasthan. Rajasthan government is different, and people there are definitely not, asking the government or so if the government is making itself accountable by making a legislation like this, by saying that it's our obligation.
I will be much pleased if any government wants to bring an act to make itself accountable.
But don't you think in a way, in a very small way, if not like, up to satisfaction level, this act is actually doing that?
No. My personal opinion is to give for a government to do something, you don't need an act. Okay. Or if you see the history of legislations of India, we have brought acts only for the people to do something. Only for the people to do something, or only for the private parties to do something, all the acts have been brought. The acts only, at least majority, maybe there will be 1 or 2 exceptions. I am not going into that. But if you just go through all the acts passed by all the assemblies and all the parliament in the past 1 year, it will essentially, either it will place a restriction on the private individual, or it will place a restriction on a private person. Okay, except like maybe Right to Information Act, Right to Education Act, such acts may be an exception, but most of the act is essentially something which controls the individual or which controls the private entity, and something which does not control the government. I am saying about most of the act. So even in this case, instead of a blanket right to health, if they had done in the phased manner, I'll give you our example. We started Accident and Emergency Care Initiative. The proposal was in 2008. GO came in 2017. The groundwork was done for 9 years. Okay. And as soon as we started Accident and Emergency Care Initiative, we made the proposal for free treatment in private hospitals for 48 hours. From a proposal to, and we called IMA, we called the private hospitals. We worked for 2 years, and then we again refined it, went to the finance, went to insurance companies, everything. And then the GO came in 2021. So without an act, okay, so far up and running, we are every day, we are treating 200 to 250 people for the first 48 hours. We have crossed 1.5 lakh beneficiaries. This has been done without an act. If the government wants to,
Yes, sorry,
if the government wants to do something, it can do without an act. The act is the act will only be the only use of an act. It's my personal opinion. Of course, there are exceptions. It will give a very glamour, and it will give space for media to discuss it. But if you really want to do good, no need for an act. For example, you may not sure you'll know or not, Tamil Nadu gives laptops for all the students in government colleges. No act was done for this.
No, but like just to come back to your point of 8 years of groundwork, I feel Tamil Nadu could afford that 8 years of groundwork because the health system was in place. But with with our SDG targets.
This is exactly my point. When you don't have a proper health system in place, do you think that you are going to do something good in the end by forcing an act on everyone?
I think, Dr. Bruno, your point is well taken, that system is needed in place for an act to be implemented.
Yes.
It's a health system's reality and truth. So I think we can go around and around on that discussion, but I've had Dr. Varun and Michal have their hands raised for a while. Can I invite Dr. Varun's comments and then have Michal come online with their comments?
Yeah, I just want to raise a couple of points. So as Dr. Bruno was asking, why do we need acts? See, very good governments come, but then sometimes they are voted out and followed by very bad governments that don't feel that you should invest in rights, you should invest in health, sorry. And they may just feel that, okay, we'll roll back the scheme, we'll roll back that scheme. But when you enshrine rights of patients in law, that cannot be easily taken away by the next government that comes in power. This is basic civics. So I'm not going to argue too much on that point. But let me also say that the goal of such acts, I think the spirit of such acts, we should also think about, because in India, the reality is out-of-pocket expenditure for patients when it comes to emergency, it often derails their entire livelihood. Okay, up to 60% of patients are paying of health expense comes out of pocket for patients in India, and very often it affects the bread earning member, and very often it puts families which were earlier just above poverty line to below the poverty line. So, and the other thing I want to point out is, I don't know, Tamil Nadu is a different situation, but in the rest of the country at least, when an accident happens or a snake bite happens, if an emergency happens, treatment at the golden hour does not happen most of the time. Okay. And when you see the geographical constraints in many places, private hospitals are probably the first go-to place for most of these kind of patients. And to say that, the government should not worry about that, or the government should say, okay, private people are for profit, let's not worry about that. Patient should have reached a government center. I think that's a very wrong way of looking at it. If the government can do something to ensure that the patient gets treatment on time, okay, whether you can always blame the government saying that they should have government centers everywhere, but it's not practical in many situations. So if the patient lands up in a private center and the government is willing to say that we will pay for the treatment in the golden hours, so the patient doesn't have to suffer or lose time in transportation, I think that's a very that's something to be applauded actually. Okay, and we can debate about this, but finally the patient's right to life is more important. Okay, then the other thing I want to say is, just like governments do bring out acts like this for the greater good, like the right to education, and it forces private players to say that, okay, you should take in patients from a poor background or a unprivileged background, and we will cover the cost. Same way, the government's trying to do something for the greater good by saying private players, okay, you make your profit, but for a small percentage of emergency for patients who can't afford, we are willing to, give that right to the patients, and we want you to support, and we will also support. I think this is a noble thing, and you cannot say that, okay, I am talking impractically or all. I have been in a peripheral center. I have seen schemes happening in Kerala. I have worked in periphery. So it's very rude to say that, we are being very impractical. We are only talking about ideals. But if you don't talk about ideals, then what do you talk about? How do you reach a society where these things matter and, we work together to achieve these kind of things? That's all I have to say.
Thanks, Dr. Barun. That's really helpful, because that's actually an excellent point. Because in the very first paragraph, the bill clearly states that its intention is to provide for free, accessible to, and equality in healthcare for all residents of the state. I do take exception with the word residents. What does that mean for migrants? With the progressive reduction in out-of-pocket expenditure in seeking, accessing, or receiving healthcare, which is an excellent thing to aspire to. And considering that medical impoverishment is a reality in India, despite all of the protection systems in place, I think this is a well-intentioned act. And as we are all seeing that there are many gaps between the cup and the lip when it comes to framing the different provisions, but I think it's up to us to advocate for making it a better act and provide a better service ecosystem for patients. Mishal, you had a question. I'd like to invite you to unmute and speak up. And after that, Radhika, your hand is raised. Please feel free to speak up after Mishal's bit. Over to you, Mishal.
Hi, sir. I'm Mishal. I'm Path's batchmate. So basically, I just had like 3 questions. One was regarding how insurance is going to run in Rajasthan. Whether anyone had any idea about that, and or whether it's just going to become obsolete. And the second question I had was regarding about the ethics of IMA conducting this strike, whether it was ethical. And the third question I had was, so a lot of the times the person paying ends up making the decisions for the family, for the patient. So when they're in ICU or wherever they are, so how will that be approached in this new system? Is my question. Sorry. Thank you.
So, Mishal, I put 3 questions. First is, what is the state of insurance in Rajasthan and how it will be affected by this act? What are the ethics? The second one is, what are the ethics of the strikes being organized by IMA? And the third question is, how does expenditure-related decision-making get affected by this act? I invite anyone to share their thoughts on any or all of these issues. Over to you.
Yeah,
Can I?
Yeah.
Yeah, I just wanted to comment on the ethics part. I think others are more qualified to speak on the other issues. The ethics of IMA, again, I sometimes feel that we are not understanding ethics. IMA is an interest group of doctors. Doctors feel that they are being cheated by this act. IMA's basic ethic is to work according to its stakeholders. Suppose I am the CEO of Maruti. Maruti is doing something and the locals are protesting that. But I know that as Maruti, my ethics is to protect my stakeholders' interest and increase its profit. It's completely ethical for me to work towards that plant is established. IMA is doing the same thing. It is working to ensure that its interest, the interest group, the interest of its stakeholders is protected. It's completely ethical, and I think it would have been grossly unethical if IMA would have failed in its job completely if it ignored and it would have just given a statement. Then why are you leaders anyway? You are leaders of the doctors of people. So you are not doing your job properly if you are not doing it.
Sir, so the analogy you made was with Maruti. I mean, like it was a company with people paying in, right?
Yeah, that is what I was making analogy, because interest groups, stakeholders.
The way
Here the
I
stakeholders are the stakeholders are doctors. There the stakeholders are
but
my shareholders.
we're
So that
not
is what I was.
stakeholders, no. We're just part of IMA. We're
Siddesh,
just
are you responding to any of these issues?
Yeah,
Siddesh,
I just feel like Utkarsh maybe revealed what my initial point was and what all of this debate has been. So Utkarsh, if I understand you correctly, if there is a point of contention where what the patient needs goes against the self-interest of the doctor, IMA will take a stand that is in self-interest of doctors, right?
Interest group of doctors, not a doctor. You
Doctors.
will not. Yeah, doctors means as a group, what is our interest? So I'm not saying that if a doctor is caught doing female feticide, you are supposed to take his you are supposed to support him. No, not at all. You should be even making a stand that no, as doctors in plural, we are against female feticide. But when the whole group feels that it is being cheated by some specific act, you are supposed, as a representative of that group, you are supposed to talk to the government through your platform. Your platform was built for this. Otherwise we would have even worse situation where we would have no communication at all. IMA is facilitating that communication.
I agree.
so,
I agree.
but the problem that is in my mind is basically the fact that if you don't agree with the bill, suddenly you're not against these doctors. Sorry, suddenly you're against these doctors. Sorry. If you agree with this bill, suddenly you're with these doctors. You're not with these doctors because you know the I think yeah, my point. Yeah, that was my
Sir,
point.
I understood your point. I mean, if
you are
somebody is
supporting the
supporting
bill,
the bill,
you are
it means
against the
that
doctors.
you are against the doctors. And that
Yeah, that's my point. So that is why I was asking about the ethics of IMA rather than a state level body doing this.
Thanks for the insights on this issue. Any other takes on the other two issues? Does anyone have insights on the insurance, state level insurance system in Rajasthan and how that would be affected? I can take a stab at trying to explain the expense decision making. I don't think that's going to change as far as the individual family level decision making processes are concerned. But I feel like if a Right to Health Act comes into being, it will perhaps ease the burden associated with medical expenses on the families. So changing the locus of decision making is a bigger, more integrated social sort of an intervention waiting to happen. This is, I feel, a more sort of a mechanism to reduce the burden of medical costs on the families, if I got your question. On that note, Radhika, I would invite you to unmute and speak up. And I think we have been online for over 1.5 hours. We will try to start wrapping up. because this conversation can go on and will go on, because we are all invested in ensuring that we have a better health system for all in India. And I think, Radhika, over to you.
Thank you, Pranab. So actually, I have a little bit of a vested interest in this situation because very recently I happened to be an attendant for a patient who was critically injured and admitted in a corporate hospital in the National Capital Territory. They had an insurance system in place which was linked to that very hospital. And it took them 3 days to clear the insurance money. They still had to deposit 3 lakhs out of their own pocket before that patient could get surgery, which would, impact the rest of their life. And this is the situation for people in the upper middle class. So my point is that when we talk about the Right to Health Act creating a form of mistrust between doctors and patients, that mistrust already exists. As attendants for that patient, we were 3 doctors, and they were obfuscating the reports. They weren't allowing us to see any reports. They weren't telling us why the surgery they told us was required at all. They weren't telling us why they weren't clearing the insurance money. So, the whole point of mistrust among doctors being towards doctors being increased by this Right to Health Act, I think is kind of a moot point. That mistrust is very much still there in the system. We just choose to ignore it when it is convenient for us. The Right to Health Act, if looked at benevolently, I think could in fact garner a relationship of a lot more trust between doctors and patients if it were implemented correctly. If there were a system in place where patients didn't have to wait for life-saving surgeries in situations of emergency just because of systems of insurance and systems that demanded out-of-pocket expenditure and deposits. So really, I don't understand why this entire question of doctors being mistreated by this act comes about.
That's an interesting viewpoint. And I think we have discussed a little bit about how or why the passions of physicians got riled up by this act. And the main reason why the worry is about mistreatment comes in is because of the allusions to the punishment that a physician may face, which is somewhat vaguely referred to within the clauses. And that raises the concern or apprehension that if something is detected post hoc or retroactively, so the act actually mentions that anything that the SHA or DHA members do in good faith cannot be held liable for litigation. Why not extend that same courtesy to the physicians instead of just putting them on a punitive platform? Dr. Bruno, am I presenting the concern correctly?
Yes, you're right. Because for the past, say, 27 years, we have got the consumer court, which finds blame on doctors for everything. No good faith on what doctors does. But if you don't have a good faith on doctor and you expect a good faith on an administrator, I don't know how it works. Okay. So that is one of the valid reasons. As I told in the comments, assume that you brought the same act. You did not have the SHA clause. You did not have the DHA clause, but you had the clause for reimbursement. Everyone would have been happy. There would not be any concern at all. Okay. The same act with the reimbursement clause and not this punitive sections would not have run into the problem. But why it was not done? Reimbursement alone is omitted, punitive sections alone is added, and you say that when the state when the health authorities does something, you can't even go to court. How is it? How can someone take this?
And this is particularly a little worrisome because, like we have mentioned before, when it comes to managing emergencies at the primary or secondary level, physicians often have to do it without the backing of very strong diagnostic infrastructure. And a lot of it is done clinically, which might insert a certain being of bit of uncertainty in the processes and threaten the physician's well-being retroactively. I see my old friend Mathan's hand raised. Mathan, over to you.
Hi, thanks, Pranab. So I joined little late. I don't know whether it was covered, this part of the issues. I just wanted to highlight certain points, which is already pointed out by my dear senior Bruno. But one thing sticks out of all the rationale that goes behind the introduction of the RTH bill and all the pertinent points raised by Bruno. Rajasthan and Tamil Nadu, when we compare their key financial indicators, health financing indicators, they are actually comparable. In spite of having a very robust public health system, our out-of-pocket expenditure actually comparable. And if you see even some of the best performing public health systems like Kerala, their out-of-pocket expenditure is even higher than Tamil Nadu and Rajasthan. So just looking at these parameters, we cannot say that a well-established public health system does not warrant a Right to Health Act. On the other hand, well-established public health systems and well-developed states actually have enough capability for individuals to seek public care outside the public health system. So we need someone behind the patient's corner to fight their case. Now, the point made by Bruno with regards to consumer courts is kind of not something which is easily available for everybody. Only few decide to fight that kind of issue. But the problem is we do not have robust systems within the health system itself to fight, to stand behind the corner of the patient or every single individual who walks into the health system, be it a private institution or a public health institution, to stand behind them and fight for their cause. That is something that as health system, we have to look at in the long term, and that is something that we have to incorporate even in well-established public health system. That is something that we have to incorporate going forward. And strictly speaking about the RTH, I think we have to look at a policy continuum in states of where we started with our health policy paradigm and then where we are headed. Are we headed towards a complete socialized medicine kind of a set? Are we moving towards a totally nationalized health system? Where are we headed towards? So if we have a very clear pathway, like where are we headed as a nation, then we will have a kind of an answer about whether we need an RTH Act today, and all the clauses and sub-clauses can be discussed further. But there has to be a policy continuum, because some state today may decide that we need to have an RTH, and tomorrow some other state may also decide to follow the act. But as a nation, where are we headed? That is something that we need to discuss. That's it from my end. Thank you.
Thanks, Martin. Some difficult philosophical questions with real world implications that I will think. I don't think I have the expertise to answer any of that, but in the comment boxes, I see Sonali has talked about Good Samaritan Acts. It is my understanding that the Good Samaritan Act works for any person who brings an injured person or a sick person or someone needing emergency care to a hospital, with the understanding that they will not be pestered going forward. But Sonali, if you're willing to come online, unmute yourself and speak up a little bit about it and enlighten us, that would be wonderful. Over to you, Sonali.
Hi, I've missed the whole discussion. I tend to come at the end in Nivarana's calls. So I don't want to go over what may have already been said. I'm not an expert in the Good Samaritan law, and maybe we can read up on it, and it may be true what Pranav had said. I would like to just ask, I have more questions. And I don't know if it's already been discussed. How is what is written in the Rajasthan Act different from what was written in Assam in 2010? And why wasn't there such a hue and cry then, which would help us understand how Rajasthan could have done things differently, perhaps? Because to my reading, a rough reading, it sounds quite similar, including emergency care services by the public and private sector.
Thanks, Sonali, for raising that point about the Assam Act. I did see that you had linked to the Assam Act on the Twitter thread, but unfortunately, I did not have time to go through that. Perhaps it will be instructive for all of us to see if the Assam Act had similar provisions. One of the major concerns in the Rajasthan Act is the somewhat vague assertion or allusion to punitive actions against physicians for that may be brought against them by patients complaining or having any grievances, and the somewhat vague provisions of getting reimbursements for emergency care provided without upfront payment, which is certainly a decent act in principle, but in implementation, it needs to be worked out well. But yeah, perhaps we need to the other thing is that there are no safeguards against rent seeking or what some have coined as the Inspector Raj that might start with a SHA or DHA that is overly weighted by administrators and with no community or involvement whatsoever, although the Act does speak about social audits. So there are some real concerns about these facts. So I think we need to sort of look at the Assam Act and see what are the key difference between the two before we can sort of highlight what the Rajasthan Act could have, what could have been done better to avoid the hue and cry that came up with it.
No, I actually went through the Assam Act as well, and I forwarded it to you. I forwarded it to you, so you can also go ahead. It's pretty much similar. It might be slightly more in depth, few clauses, but it's actually seems like it's like a copy paste, some of the sentences at least. But yeah, it's a very valid point which Sonali has raised. I'll have to dig,
And I think if it was passed in 2010, there must have been at least one or two cases, if not more, of emergencies being handled by the private sector. And, has any reimbursement happened? Has it not happened? I think that would be informative. And if nobody's asked for free treatment, then I think people in Rajasthan can relax, hopefully. And if people have asked for treatment and the government has not paid up, then that's an issue. Then it gives more substantive evidence to the people who are protesting that, look, it happened in Assam. People did not get paid. What are you going to do to avoid this situation in Rajasthan? So from both angles, I think we have a precedent which we can really look into. I would also encourage people to, I'm quite delighted that this is actually leading to a lot of people engaging in these discussions about health systems. And I really liked what somebody said about policy continuing. And I think we don't have a unified vision for where the health system is headed. And we are just, derailing into a very privatized system. And in my conversation even with private providers, and I think most of the private providers here would also agree that majority of care in a country like India should be in the public sector. But that's not what is happening. And there doesn't seem to be a vision to stop that train from speeding in the wrong direction. So I think all of us on either side of the spectrum, hopefully, maybe there's some naysayers, which is fine, can at least begin to get more involved in health system discussions, read more, educate ourselves. Even for us who are in public health, a lot of this, every time an issue comes, we have to read up, we have to educate ourselves. So I would encourage everyone to get involved in these kinds of issues. So I think that's, one good side effect of the whole issue, that more people are getting engaged in these conversations.
Yeah, if I can just ask Radhika to share her thoughts. She has worked in Assam. If you had noticed anything related to the right to health act there in Assam.
To be honest, I think the only difference was I don't remember if they mentioned the DHA, SHA like specifically. There were, I think, inclusions for legal action to be taken for enforcement of the Public Health Act. But I think one of the major differences is that, yes, I am not sure if they mentioned any SHA or DHA enforcement authorities as such.
No, but the
And if yes, the reimbursement did happen, and they also what I remember very specifically is that for children with congenital heart diseases or children who had to undergo chemotherapy not available in Assam, the state government with a private public partnership also ensured that they would receive out of state treatment with full state reimbursement as well. I think because Assam itself didn't have that, doesn't till date have very advanced private healthcare either. Most of it was, I think, concentrated on out of state expenditure in the private sector. I'm not sure if that was the extent of it. In private sector, there wasn't really much of a hue and cry about it. But yeah, the state reimbursements, as far as I know, were always on mark.
Yeah. No, thanks for that. And actually, Pranav, you brought out a very relevant point that, this act actually talks about HRH as well, which again is a very relevant area to focus on.
What I like about this act is that it lays down the groundwork for developing the systems in several frameworks, human resources in health. It talks about pandemic outbreak preparedness. It talks about a state public health policy. All of these are really great because it builds up towards, at least on paper, strengthening the healthcare systems in place. Now, how that is implemented and designed is a different issue altogether, but the provisions are encouraging for someone like me, who has always wanted to see a structured approach to healthcare governance, public health governance in the country. So I think these are all encouraging signs. And Sonali, your point is well taken. And I agree that we need to be health systems oriented a little bit more. And I feel some of the provisions in the Act, as they stand now, are a step in the right direction, but I'm not sure how the next steps should follow. That is where the role of the larger civil society advocacy comes in to sort of help frame it in a more logical and implementable fashion. I see your hand is up again, Sonali, over to you.
I don't know if this conversation's happened, but the idea of a right to health is considered a progressive right. So it doesn't mean everything, everywhere, all at once, referring to the movie. So it's not that the state is magically going to provide care for everyone, but it does in the Act say that there will be progressive commitment towards the right to health. And a lot of people feel that talk of human rights is wishy-washy. Somebody mentioned toothless, etc., right? No one thing is going to change the world or eliminate poverty and make everything perfect. But every little commitment, every little policy commitment is a step in the right direction. And I think both, in my opinion, both stances, extreme stances, are not useful. On the one hand, rejecting the entire act because we don't agree with one or more clauses. There's a whole list of obligations of the state in the act. We should encourage the government to retain that and, probably develop a charter or a well thought out list of things that, need some clarity. And I think also educate ourselves on what are the actual demands and what are some things we are misunderstanding. So one of the requests that I saw online was, why haven't they mentioned the reimbursement packages and amounts? And then somebody else, I think Dr. Soumitra, said that, if you put the amounts in a parliamentary act, then you need an amendment to change the amounts. So certain things can't be put in an act. So being upset that that is not being put is not really relevant. What is needed is a continuous engagement to make sure that there is some level of, it won't be perfect, but there's continuously some level of conversation happening as this act is operationalized, so that, you know, demands can be sort of reasonable from both ends.
I think Vishal wants to say something next. We already have crossed almost 2 hours. So just few closing comments, and then I think, yeah, Vishal, please go ahead.
Sorry. Yeah. So I just had one last question. So, you know, like we're talking about, so my question is about if, you know, this whole system works and the government does reimburse hospitals on time and they get the money. Do you think that the hospitals are then going to be incentivized to charge more because the government is paying for it? And is that okay? Is my question.
I think Dr. Bruno, if you would like to answer that.
No, I didn't. I was typing. Can I repeat the question? I'll answer.
He's trying to,
Honorable
yeah.
sir,
No,
sir,
please.
so basically, if the government is paying for the treatment,
yeah,
and the hospital gets the money like on time,
okay,
is it then the hospital will be incentivized to increase the prices of everything?
no, this is why actually if you see what we did in Innoir Kapam Thittam, essentially what we have done is the patient is taken by the 108 ambulance. That time itself, the patient is codified into what a red, yellow and green. Okay. So, and the major injuries are noted. So for example, there the prices is fixed per procedure. Okay. Suppose you are doing an intubation, we have factored in the say cost of the ET tube, the gloves, etc. And it is procedure based. For example, if the patient GCS is 15, hospital cannot charge for intubation. Okay. Or for example, when the patient has a fractured femur, cost of the Thomas splint is factored in. Okay.
Sir, I agree, sir. But like in Rajasthan now, that's not the system.
That is exactly what I was mentioning few years ago. Now, when you don't have a system and when you bring this act, you are going to do more damage. I will tell you what will happen is, first, the government will not pay. Okay. Then slowly hospitals will not treat. Okay. Then government will pay a lot. And then there will be lots of money will be, then you will have pay, underpay, then you will overpay. And in the end, it will be a lose-lose situation for everyone concerned. So that is why I am saying this should have been in a phased manner. You should have done a trial in one taluk or one district, and then only you should have come up with an act. The act in the present form will not do good to anyone. I am no way related to Rajasthan, yet I am so critical about this is because I am able to visualize what are the problems will be happening. The intention of the act is good, and I am watching for the past 2 days in Twitter. Even here, everyone who is supporting this act is supporting right to health. Okay, whereas those who are critical of this act are critical about the specific points. No one is opposing a right to health act. Let us be very, very clear on this point. Okay, so if you are supporting the right to health, we are also supporting the right to health act. That point is settled. We are only worrying about the speed at which it is implemented, and not doing proper study and not doing the proper groundwork. No one will know. For example, if you ask me to write an act for Rajasthan, I cannot do it without knowing how many hospitals you have, how far you have from each other, what are the facilities, what are the government facilities. An in-depth study must have been done, and then only this act must have come. Even now, okay, you have even now having enacted it, I think the solution should be to be liberal in reimbursement. Of course, few hospitals may overcharge, but you see, you cannot avoid it. Essentially, sometimes in healthcare, what happens is, if you go too tight, the people who are supposed to get benefit will be affected. Suppose you want to benefit everyone, there will be 15% who will be profiteering. I will use the word profiteering here. So you decide if you want to have a right to health, you must be ready to spend money. If you are not ready to spend money and just say right to health, it will end up in disaster, and the healthcare delivery will become worse than what it is now. I fully agree that private hospitals, if not all, say 10 to 15% may overcharge. But you really don't know the situations why they are overcharging. For example, for them, the consumable may be high. Take a simple example, cost of water. Some hospital will get a tank, lorry tank of water for 700 rupees. Another hospital will have a tank of water for 3,000 rupees. You cannot expect both to have the same charge. So for this to be successful, if you really want the Right to Health Act, you have to give more freedom, at least in the initial phases, to the healthcare providers. Unfortunately, you have not given them money and you have curtailed the freedom with the health authorities, and hence I am not sure how this will turn up. Did I answer your question or did I blabber something?
Yeah, sir, you answered. I understood. I think your stance is you need to keep a limit on how much you're spending.
Yeah, for what is the gross? We cannot say we cannot make the bill as 23,345. That is not possible. But a fracture femur with no other injuries, what will you pay? A fracture both bone, say polytrauma. I think I will share. I think I already shared the Tamil Nadu people. I can also share it with you. If you go through that, you will understand how it was made.
Sure, sir. Sure, sir. Yes, sir. My doubt was basically that, sir, whether it will increase and whether it is okay.
100% it will increase, sir. And not everyone, sir. 5 to 10% will game the system, sir. Whatever rule you bring, sir, there will be 10 to 15% who will be ready to break it, sir. But the point you have to understand is, if you are trying to prevent those 10 to 15 people, you will end up suffocating the genuine beneficiaries.
Sure, sir. Sure, sir. I understood.
Thank you. This has been a 2-hour-long discussion session, and I think even as a pro person in favor of a bill or legislatory instrument bringing the right to health to everybody, I find that there are a lot of nuances that need to be clarified for the Rajasthan bill as it stands now. And I think it's important mainly because if this goes through, it will set a precedent for other states to follow through. And that's what makes it more important to get this right when it is getting implemented, because you don't want other states to follow in the following steps or get dissuaded by the protests that ensue after this gets into an implementation mode. So I think there's a lot to be discussed and a lot of nuanced details that need to be highlighted on how we can improve this. One thing that I have realized throughout the 2 hours that we have been online is that irrespective of our stance on how the current legislation stands, we are all in favor of equitable, accessible healthcare systems that works for all. That is without a doubt. I'm thinking that, Parth, correct me here, as we go forward, there is room to sort of summarize what we have been discussing today for 2 hours in a short document. And we can try to bring in the various insights presented during this call and identify recommendations on how we can improve the act or bill as it stands now and make it a more, a better, a stronger, and more people-facing piece of legislation. With that, I am turning it over to Parth. Thank you for organizing this. Thank you for bringing us all together. And thank you all of the speakers and panelists for getting online and spending so much of your time and energy in discussing this. It clearly shows that the amount of passion we all have for this, improving the public health in the country. And thank you for all your wonderful insights. And I must say, I learned so much just listening to all of you. Over to you, Parth.
I would like to say the same thing. Thanks a lot for everybody who has taken out time to join this conversation. And I personally have learned a lot today. I was totally pro before this, but now I have a better understanding of this whole act. And especially the insights that Dr. Bruno has shared definitely has helped me understand this better. So thanks a lot for that.
We are all pro act only, no doubt on that one.
No, but now I see flaws. I see flaws and I understand them much better, is what I'm trying to say. And there is definitely a scope of improvement. And like Pranav mentioned, we both will try to summarize this whole thing, come up with a piece of our recommendation based on this discussion, and we'll definitely share it with you all as well. So thank you once again for all your insights. And this recording will go up on YouTube, and I will share it with you all as well once it's uploaded, so that we can again sort of inform the masses and increase awareness regarding this act. So once again, thank you all, and I hope you all have a great weekend, weekdays, entire week. Yeah,
It's going up on YouTube.
Yeah, I'll share it on YouTube, Michelle. Yeah.
I could have asked more like interesting questions, no?
Okay. I'll stop recording now.